Hello, my name is Jeremy Rees. I'm a consultant neurologist and I work at the National Hospital for Neurology and Neurosurgery, Queen Square, which is part of University College London. I'm an honorary associate professor at University College London, and I have extensive experience in the management of brain tumours and neurological complications of cancer. I also work at the Cleveland Clinic London. So first of all, a brain tumour is a growth of abnormal cells within the brain. And you can have tumours which come from other parts of the body, which are called brain metastases, or tumours that grow from within the brain itself, known as primary brain tumours. My main work is with patients who have primary brain tumours, and I specialise in looking after patients with slow-growing primary brain tumours, which are called low-grade gliomas. And I have a number of patients who I'm pleased to say have survived for many years, even up to 2 decades, following the diagnosis of their brain tumour. When I first started looking after these patients, their expected survival was between 5 and 7 years. Nowadays, we expect patients to survive at least into their 2nd decade. And I've done a number of interesting research articles into this area, and I've shown that the major change that has caused this extended survival has been the use of early brain surgery for patients with these low-grade brain tumours, to the point now that every patient that comes to see me with a low-grade glioma will be very carefully considered for brain surgery before anything else. So I have many patients with low-grade gliomas. The diagnosis is usually an astrocytoma or an oligodendroglioma. Oligodendroglioma patients generally survive longer than astrocytoma patients. Having said that, I have a number of patients with astrocytomas who've survived 10, 15 years. I'm thinking of one particular individual who I first met when I was a consultant at Watford Hospital and who presented with his first epileptic seizure, and he's still alive today, 13 years later. So the patient was experiencing initially epileptic seizures, and that's what actually brought him into hospital. However, once I'd started treatment for his epilepsy, the seizures came under control and we monitored the tumour at the time. Fairly shortly after the diagnosis, I can't remember whether it was 1 or 2 years, the tumour started to grow and looked malignant, and so we operated on him. And following that, we diagnosed glioblastoma, which is a highly malignant form of tumour, and we gave him radiation and chemotherapy, which at that time was a relatively new treatment for glioblastoma. This was around 2006, when previously patients would only be given radiotherapy treatment. And as I've said, I'm still seeing him now in my clinic, 15 years later. So the patient was treated initially with surgery. Because of the location of his tumour, it was not possible to operate and remove the whole tumour. And this was followed by a 6-week course of radiation treatment, which we call radiotherapy, together with a drug called temozolomide, which is a form of chemotherapy, and then another 6 months of the chemotherapy after the end of radiotherapy. And that treatment sufficed in controlling the tumour for many more years. About 2 to 3 years ago, the tumour started coming back and began to affect his ability to speak and to communicate and to express himself. And so we restarted him on chemotherapy treatment. Throughout this time, he's had occasional epileptic seizures, which I've treated with anti-epileptic medication. So after the treatment with the radiation and chemotherapy, he lived a very good quality of life. He continued to work until his retirement. And only in the last 2 to 3 years, when his speech has become more difficult, has his quality of life been more significantly impaired. And that is unfortunately the nature of brain tumours, that when they do come back, often their patients become more symptomatic and their quality of life declines. Nevertheless, he's still living at home with his wife. He still manages to get out and enjoy things. There really has been, I think, a significant improvement in the survival of patients with low-grade gliomas. And it's very interesting looking back after over 20 years doing the same job, that I can feel with some sense of satisfaction that patients now are living longer and living better because of the more aggressive approach that we are taking towards these tumours.